Conjunctival hyperemia presents a persistent clinical challenge. Misdiagnosing the exact cause of a red eye carries immediate risks: prolonged patient suffering, accelerated transmission of a contagious virus, or severe iatrogenic damage caused by the wrong pharmacological agents. This matrix serves as the primary filter for any red eye presentation. By analyzing clinical variables, we rapidly rule out infection and isolate allergic disease. The first variable is the patient's discharge profile. In bacterial infections, the discharge is thick and mucopurulent. By contrast, viral adenovirus infections present with a watery or serosanguineous tear film. Allergic disease presents an entirely different profile. In severe cases like vernal keratoconjunctivitis or VKC, thick, ropey mucus becomes mechanically trapped between large conjunctival papillae. Misidentifying the nature of this discharge risks initiating a completely incorrect clinical workflow. The discharge assessment is the mandatory first filter. With the discharge categorized, we apply the primary symptom checklist to further differentiate the etiologies. A viral presentation typically involves photophobia and sequential bilaterality, where one eye becomes inflamed first, followed by the second eye a few days later. A bacterial presentation has a rapid onset. Patients frequently report waking up with matted, crusted eyelashes. Allergic conjunctivitis carries one definitive clinical hallmark: intense, undeniable itching. If a patient with an allergic eye disease does not complain of itching, the diagnosis should be reconsidered. The final diagnostic criteria rely on observable clinical signs across the conjunctiva and cornea. Viral signs include corneal subepithelial infiltrates and the formation of pseudo or true membranes across the conjunctival tissue. Allergic signs present as distinct structural alterations: tarsal and limbal papillae, and the presence of Horner-Trantis dots, which are focal collections of eosinophils at the limbus. Ruling out bacterial and viral infections using these clinical markers allows management to shift toward preventing the irreversible structural damage unique to severe allergic disease. This diagram compares the two predominant allergic pathways. Seasonal and perennial allergic conjunctivitis are primarily IgE-mediated, driving a rapid histamine release. VKC, however, relies on a chronic T-cell and Th2-mediated inflammatory cascade, bringing a sustained influx of eosinophils to the ocular surface. Both of these pathways trigger severe itching, but the physical act of eye rubbing severely exacerbates the inflammatory loop. The mechanical pressure physically degranulates mast cells, forcing them to release even more histamine into the tissue. This cross-section shows the mechanical consequence of that friction. The mechanical trauma from rubbing actively sheds the protective epithelial barrier of the cornea. Once that barrier breaches, matrix metalloproteinases, or MMPs, from the tear film gain deep access directly into the exposed stroma. These MMPs induce rapid stromal melting, chemically dissolving and degrading the cornea's collagen matrix. As the collagen weakens, normal intraocular physical outward bowing of the cornea. This mechanical failure drives the development of keratoconus. Halting this process requires strict patient counseling. You must explicitly prohibit eye rubbing. Instruct the patient to use cold compresses to vasoconstrict the vessels and reduce itching, and prescribe protective glasses to block environmental triggers. The physical act of eye rubbing acts as the primary catalyst, translating surface-level inflammation into the irreversible, deep structural failure of the cornea. That same mechanical friction also generates one of the most severe complications of allergic eye disease, the shield ulcer. This is an oval or pentagonal epithelial defect, typically located superiorly, directly near the visual axis. Shield ulcers occur because giant upper tarsal papillae act like cobblestones, relentlessly scraping against the delicate corneal surface with every blink. This diagram illustrates Cameron's grading system, which dictates exactly how aggressively a shield ulcer must be treated. In grade 1, the defect has a clear base and often responds to topical steroids and a bandaged contact lens. In grade 2, the base begins accumulating inflammatory debris, but remains manageable with intense topical therapy. The critical danger lies in grade 3. Here, the debris hardens into a dense, elevated plaque composed of fibrin and mucus. This elevated plaque physically blocks reepithelialization. As long as that solid barrier is stuck to the stroma, natural cellular healing is physiologically impossible. Failing to identify and surgically debride a grade 3 shield ulcer guarantees a permanent corneal scar right in the visual axis. Aggressive early intervention is the only way to protect the patient's sight. This clinical ladder shows the treatment protocol for ocular allergy. Pharmacological escalation is dictated entirely by one specific threshold, the presence of corneal involvement. In the mild tier, the patient experiences itching and mild redness, but slit lamp examination confirms the cornea remains completely clear. The standard treatment protocol here utilizes dual-acting agents, such as olopatadine at a 0.1% or 0.2% concentration. These agents are effective because they provide immediate antihistamine relief to stop the acute itching, while offering long-term mast cell stabilization to prevent future degranulation. We move into the moderate tier the moment the cornea becomes compromised. Clinically, the patient will present with intense photophobia. This tier is marked by focal limbal inflammation, Horner-Trantis dots, or superficial punctate keratitis. This objective evidence of tissue damage requires an immediate shift to pulse therapy, utilizing low-dose topical corticosteroids like fluorometholone. The strategic goal of pulse therapy is to rapidly break the acute inflammatory cycle on the ocular surface, clear the corneal lesions, and aggressively taper the patient back down to maintenance drugs. The transition from antihistamines to steroids is a mandatory reaction to objective visual evidence that the inflammatory cascade is destroying corneal tissue. Escalation is based on tissue damage, not patient discomfort. At the peak of the ladder is the severe and chronic tier. These patients present with macroerosions, large cobblestone papillae, active shield ulcers, or a clinical history of immediate relapses during steroid tapers. This creates a critical pharmacological timeline. Because topical steroids cannot be maintained indefinitely, the hard pivot trigger occurs when steroid reliance exceeds 2 months. Prolonged topical steroid use in chronic patients introduces severe iatrogenic risks that rival the underlying disease itself. This cross-section illustrates 2 devastating complications of chronic steroid exposure: steroid-induced secondary glaucoma from sustained intraocular pressure and posterior subcapsular cataracts. To bypass these risks, steroid-dependent patients require a hard pharmacological shift to a topical immunomodulator, specifically tacrolimus or cyclosporin. Tacrolimus provides a distinct pharmacological advantage. It stabilizes the T-cell-mediated inflammation for a long-term 6-month maintenance course, completely bypassing the intraocular pressure spikes associated with corticosteroids. Successfully managing ocular allergy requires a strict sequence of logic: accurately ruling out infection via the diagnostic matrix, physically stopping the mechanical trauma of eye rubbing, and precisely timing the shift to immunomodulators before the treatment itself blinds the patient.